So can everyone hear me? I wanted to just thank the program committee for inviting me to talk about different things that I do at MD Anderson. I'm an associate professor at the Department of Pain Medicine. So we do quite a bit of vertebral augmentation at our center because of multiple myeloma, a lot of vertebral metastasis with compression fractures. So I was told to show a video. I have a video at the end. But before you watch the video, I wanted to give you a little bit of basics. The lecture beforehand was very, very good. I cannot stress enough what he said about understanding anatomy when you do these more dangerous procedures with big trocars, because you can injure structures nearby. I cannot stress enough that you need to understand 3D anatomy, because a lot of us do these procedures under fluoroscopic views, which is 2D anatomy. 3D anatomy requires CT scanning, where you can see axial views when they reformat the images for the axial view. A lot of us don't have that luxury. So I'm going to go through the very basics of vertebral augmentation and talk about the difference between vertebroplasty and versus kyphoplasty, and talk a little bit about the newer things coming out and what to look out for when you start your practice. These are my disclosures. I do a lot of clinical research and collaborations with a lot of other companies. So the difference, very, very basic difference between, so under this umbrella is called vertebral augmentation. Vertebral augmentation means that you're either doing a vertebroplasty or some type of cavity creation. So vertebroplasty just means you're injecting polymethyl methacrylate or silicon type material, bone cement, into your vertebral body. And you do not create a cavity. That's a vertebroplasty. A kyphoplasty, the difference between that is you're creating a cavity. So it's cavity creation either by a balloon, that's what they discovered first, was balloon kyphoplasty, is vertebral augmentation with a cavity, or now there's different ways to create a cavity, including coblation technology, including implant technology, also including osteotomes. And we're going to discuss that a little bit before we go onto the video. So this is a case that I performed, and this is an example of a vertebroplasty, but you can barely see the spine, very scoliotic spine. The reason why I chose to do vertebroplasty on this person is because it was an older fracture. If you have a person with an older fracture, if you're trying to reduce that bone with a balloon or an implant, the likelihood of you being successful to reduce that bone is very low because it's starting to sclerose. So even though there's a compression, a wedge, the best thing to do is stabilize that wedge, and you could do a vertebroplasty. So this is an example of a kyphoplasty. So on your left, this is a balloon I'm inserting in the vertebral body. The balloon then I inflate. When you inflate the balloon, you're in effect reducing that bone so that you can restore the height of that compression. And then after you inflate the bone, create the cavity, you then deflate the balloon and then take it out, and then you're left with a cavity. So that's the cavity creation, makes it a kyphoplasty, and then you would then fill it with your choice of cement. And so on your right, I filled that vertebral body with a polymethyl methacrylate. So other ways to do cavity creation is something called using an osteotome. Many different companies have different osteotomes. And what an osteotome is sort of a blade or a stick that you would put in the medullary bone of your vertebral body, which is very soft. So if you're putting in that sword or stick, or what we call an osteotome, you're making tracks. So this is an example of an osteotome, where I'm making tracks for my cement to go. So I'm making my cavity for that cement to follow those tracks and leak into that track that I've formed. This is one of the newer osteotomes on the market. previously, maybe almost 10 years ago, the first type of osteotome was called an archoeplasty, where you made little arcs and tried to make different cavities. You might see a lot of these different things, but in general, an osteotome is you're making tracks without a balloon. So the difference between cavity creation and no cavity creation is not only the name, but no cavity creation is injection of your bone cement with high pressure. So you're injecting it in this medullary bone. It's high pressure injection. You didn't make a cavity. For kyphoplasty, cavity creation, it's called low pressure injection, because now you have a cavity that you're filling up in low pressure. Some people think it's much safer to do that because then you have control of your cement spread. So that's the difference. Why are sometimes people choosing vertebroplasty versus kyphoplasty or cavity creation? It's because you can control cement spread. It's very important to have good control of your cement spread. Ways to do that is consistency of your cement that you're injecting. The more viscous it is, the more control you have to keep it within bone. If you have a very low viscosity cement, or you didn't let it set up until before you inject it, it may leak out through the vasovertebral arteries and that system, and then you have a leak. So it's very dangerous to have cement leak, because if you have cement leak posteriorly, you can disrupt the neural axial space and cause a lot of damage to your spinal cord and your nerve roots. So this is something new. This just got FDA approved last year. There's a few years ago, there's this stackable type equipment that was used that would help raise and reduce your vertebral body. So this is a PEEK implant for which physicians can access the vertebral body the same way they would access the vertebral body with a vertebroplasty or kyphoplasty, but instead of putting a balloon, instead of putting an osteotome, instead of just injecting cement, we're now implanting these PEEK springs to, as you're turning the spring, you're opening up, you're putting more pressure on the end plate so you could raise that vertebral end plate. What's very nice about this is your goal is to not spread cement posteriorly. The cement, as you inject, comes out of this implant in these little holes interior to the implant and will typically just stay within that implant. So we're improving with regards to control of cement spread. We're improving with regards to the reduction of vertebral height. So this is new, and there might be more of these types of things to come for vertebral augmentation. So I'm going to talk about the procedural steps, and it's typically very difficult to get fellows to think in 3-dimension. So really easy ways to think about this is a stepwise approach in accessing your vertebral body through the pedicle. So if you look at the axial view of your vertebral body, which we don't have the luxury of doing this fluoroscopic guidance. You look at your pedicle, which is right there, and then the arrows are pointing towards your target. There's two ways to approach that vertebral body. One way is the conventional transpedicular approach, which means you're going right through the pedicle, you stay in the pedicle the whole time, and then you end up in the middle of that vertebral body. Once you get used to this procedure, you can really target your trajectory and aim and focus towards the superior end plate, inferior end plate, depending on where the crack is, where you want to reduce. And once you get more and more savvy and used to it, you can then target your osteotome or your even radiofrequency ablation needle and burn off tumors, and that's what we've been doing at my institution. So that's transpedicular, right through the pedicle. So you have to have this in your mind. The next way is a conventional extrapedicular. The reason why I sometimes use extrapedicular is for any level above T6. Because any level above T6, when you're in the lumbar spine, your pedicles are more oblique. in orientation. As you go up the spine towards the cervical spine, in the thoracic level, your pedicles are more sagittal. So what then happens is that if you're trying to do a transpedicular approach higher up in the spine, say T3, T4, or 5, what happens is that you're just going to go in straight in, and you might pop out of the lateral border. Does everyone get that? Because then you're just going straight down that sagittally placed pedicle rather than obliquely placed pedicle going into the vertebral body. So above T6, typically in the Caucasian population, I go extrapedicular. I don't go through the pedicle. I go off to the side, typically at the rib to vertebral junction. Go through that and pop into the vertebral body. In a smaller population, the Indian population, you're much more petite than we are in the States. Probably lower down in the spine, you might need to consider an extrapedicular approach. So knowing that, we don't have that axial view in our mind. This is why you have to imagine that 3D anatomy. You always have to imagine where you are in the axial view. You always have to imagine your trajectory and your endpoint. And so if you look at the typical transpedicular approach, and if you're just starting off doing this, this is what I would recommend you start off doing, transpedicular. And so what you see in the lateral and the AP views is what you see with fluoro. And if you start off at number 1 position on the AP, number 1 on that pedicle, and so here it would be at the 10 o'clock position, that AP view. This would correspond, when you get your lateral view, to the face of that pedicle, number 1 on the lateral. And as you're advancing this needle in sort of that oblique trajectory starting off at 10 o'clock, you're going to advance it very gently, not to violate the medial portion of that pedicle. Because the medial portion of that pedicle corresponds to this, which you can't see, which you have to imagine in 3D imaging. Medial portion of that pedicle would correspond to this. And if you violate that medial portion of that pedicle, you're in the neuroaxial space. So you can get CSF, you could injure nerve root, you could keep going and injure and get a spinal cord injury. You never want to violate that medial border if you're not in vertebral body yet. So as you're placing that needle and navigating it through that pedicle, you also want to remember that where this wire is on that picture is the most narrow part of that pedicle. The most narrow part of that pedicle is called the waist of that pedicle, and it corresponds to the medial border on the AP view. So that is your danger zone. Do not violate that if you are still in pedicle. You may violate that on the AP view if you are now in cortex, in through cortex. So, stepwise approach, number 1 and number 2 should correspond in your AP and laterals. Think about 3D, think about that. And once you're at number 3 on the AP, the medial border of the pedicle, you should be at cortex. By the time you're at cortex, then you want to start going more medial, medial, and medial until your final position is at about the spinous process level. Because then when you're through cortex, you're okay to go medial because you're away from dangerous structures. Right? So you got to keep reviewing, take pictures of this, because this is the easiest way to teach fellows and understand 3D anatomy and navigation of that needle using fluoro. So the extrapedicular approach, I'm going to skip because I don't think you've done augmentations yet, and this might just confuse you, but take a picture of this as an extrapedicular approach. Again, this is outside of the pedicle, but you still use that pedicle as a landmark to understand where your needle tip is at all times. So, I'm going to talk about the indications, contraindications, and some complications that can occur. This comes from the Society of Interventional Radiology, and this is very old, and it still remains true, that the indications for this procedure includes painful osteoporotic vertebral compression fractures refractory to at least 3 weeks of analgesic therapy. This is 3 weeks is in contention because if someone's had a vertebral compression fracture so severe and they're bedbound and they've been bedbound for a week and can't even move because it hurts too much because of the mechanical pain, and they're in bed and they're in the hospital, they can't get discharged, I would consider doing it then. So this is a guideline, not law. Painful vertebral bodies due to benign or malignant primary or secondary bone tumors. This is my world. I do this for them all the time. Painful VCFs due to osteonecrosis or something called Crumel's disease. Very rare. Do I see that? Reinforcement of vertebral body prior to surgical procedure. So sometimes I get called in if the surgeon does not do augmentations, and we do a phased procedure where I do an augmentation at one level. So the person's very, very osteoporotic, say they need to do vertebrectomy. I'd cement the level above and below the vertebrectomy site so that they can put in their pedicle screws and keep that in place if they're doing a fusion. Chronic traumatic vertebral compression fractures with non-union. You have to show that there's non-union. You can see that on a CT scan to see if that there's non-union at that level. So contraindications include asymptomatic VCFs. So vertebral augmentation is indicated for pain. If the person does not have pain but has a fracture, you should not do it because there's no evidence that that would be at all beneficial for that patient. Patient improving on medical therapy. If you look at the patient, and there's been literature out looking at the healing process of vertebral fractures, at about a year, with or without vertebral augmentation, a fracture will heal. A fracture will no longer be painful, which means that that's a contraindication. You do not cement a non-painful fracture. Ongoing infection, obviously for any intervention, you don't want to do it for ongoing infection. Prophylaxis, so somebody's osteoporotic, so you decide, oh, well, I'll cement their whole spine. That is a contraindication. Uncorrectable coagulopathy, myelopathy because of retropulsion, and allergy to PMMA, or the barium that is put in PMMA and they're allergic to barium. So relative contraindications. So this all depends on your experience and your comfort level with the procedure, and it's also patient specific. Radicular pain is a relative contraindication. Sometimes I still do it with radicular pain just because it may be a radiculitis and an inflammatory pain rather than actually a bone hitting the nerve. Vertebral compression fractures greater than 70% height loss, so it just becomes a lot more technically challenging. If you're more experienced, you could potentially even do it for vertebroplana, which is more than 90% loss. Unfortunately, I don't have pictures of that, but that is done on experienced hands. Severe spinal stenosis, asymptomatic retropulsion, and bony fragments. Be very, very careful because those fragments can hit nervous tissue. Tumor extension, epidural into the epidural space, or epidural tumors, and lack of surgical backup. If you're not a neurosurgeon or a spine surgeon that can get this PMMA off of the dura, you need to get one to back you up, because if you start seeing the cement leaking backwards and then in the recovery area they have neurologic compromise, you need to be able to have backup right away to take it right away off of the dura. And that is a very, very difficult and irritating procedure. So definitely if you're an interventional pain physician and not a neurosurgeon, you need that neurosurgery backup. So complications can happen. Vertebroplasty complications are typically short-term, and the complication rate is less than 10%. You can get foraminal epidural cement leakage into the disc. Typically, if you leak into the disc, it's inconsequential. There's no clinical problem with that. Problem is, evidence is coming out if you're messing with the disc, if you're putting cement in the disc, and it's messing up this very minimal blood supply to that part of the disc. You can get increased degeneration. In general, leakage has been reported in up to 65% of cases, most of them asymptomatic. A story at my institution, one of my partners did a vertebroplasty, multiple level vertebroplasty, and the patient did very well, very good pain reduction. The person was doing cancer surveillance imaging that was scheduled. What they found was that there was polymethyl methacrylate in the heart. Asymptomatic, the methacrylate went all the way up into the heart. So it can spread in awful places, but a lot of times it's asymptomatic. Others, you can get rib fractures. These patients are osteoporotic or very fragile, so even positioning for this procedure can cause even more fractures. You can get thrombus, foreign body reactions to the cement, and pulmonary embolism. There's reports of pulmonary embolism reduced in frequency only because we've learned to not use as much cement as we did before. These are my complications. Luckily, these are my complications that did not have any clinical consequence. And if you can see this, it's probably very hard to see that ball right there. That's a kyphoplasty. The cement stayed in that ball, stayed in that cavity. I was very happy with that. But during the procedure, that kyphoplasty, if you can see that the cement went posteriorly, it went all the way posterior into the posterior longital ligament. Luckily, it stayed there, and this is how it looked during the procedure. You can see that it leaked back. If you start seeing that, you stop injection because you don't want it to leak back even more and cause nerve injury. I got a CT scan with that reconstruction there, and you see a bunch of polymethyl methacrylate in the posterior longitudinal ligament. This patient, I disclosed that this happened. She was asymptomatic. She was very happy that there was a good pain relief, but this can happen. So what do we do by this? We learn different techniques. One technique that is done, and I do it often for bone that I'm concerned about with a very poor posterior cortex, is something called an eggshell procedure using a balloon. I would, before I inflate the balloon, I would put a tiny bit of cement in the bone, and then put the balloon in, inflate the balloon, and now I have a guard. Let that settle in, and then before I inject more cement, I have an eggshell. And that eggshell would potentially keep the cement in place. So that's called the eggshell procedure for augmentation. So this is the video. I'm going to talk through the video of my fellow. I'm videotaping my fellow towards the end of his fellowship, doing a procedure solo, and I'm just videotaping. So it's a rather elegant procedure. This person is under general anesthetic. You could actually do it under MAC anesthetic, and some people have been doing it in their clinic setting. And what you do is localize with local anesthetic. Again, under fluoroscopy, very aseptic technique. I hang antibiotics 30 minutes prior to starting. That's the small skin incision that we have. We're using 8 to a 14 gauge needle, and so that's what he's doing. So under X-ray guidance, we're advancing the trocar and taking AP and lateral views. So this is the AP view, and again, so this is at about 10 o'clock position. Some of my patients have very hard bone. We sometimes mallet, sometimes you could screwdriver it in. So very gentle advancement of that. So you could see that he has not violated the medial border of that pedicle. He's at position 2, approaching position 3, and that corresponds to the AP view. And so he's accessed that. Now he's doing the other side. A lot of interest now is doing a unilateral approach because it's much faster, and the tools coming out is allowing us to do unilateral approach very well. Sometimes if you want to do balloon reduction, bilateral approach might be more beneficial because you have a lot more surface area to raise up the end plates. So he's placing that next needle on the other side. Same approach. And then, so see on the left on your left needle, it was position 5 at the spinous process, and now he is trying to get to the same place for the right needle. Yeah, so this is because of positioning of the patient. So in order to get the AP view, it looks like that's a little bit oblique, just because the patient was not positioned correctly. But it's AP, right. So again, we didn't violate the medial border. Here's two needles going in. And so at this point, we're probably beyond the cortex, and now you see him pushing it more medially. You never want to advance the needle in the lateral fluoroscopic view unless you're in the cortex, unless you're sure you're in the cortex. So now both needles are in. There is a screw, bone screw put in, so both are very midline at position 5. Then this is the balloon that we put in. The two tips of that balloon is the size of the balloon. We're inflating the balloon now. And we're trying to make our cavity or even reduce the bone. So you can have the bones kissing side by side on top of each other depending on where you want to put it. So this is the cement injection under live fluoroscopy. There's so many different options that you could, this is under live because you want to make sure that you don't go posterior with the cement. And you want to be very controlled and smooth and keep your eye on the image. Live fluoroscopy. So there's many tools now. This is, I call it the plunger. I forgot what the name is, but there's many different tools to put in the cement, and you can stand way far away, press a button, and the cement will spread, press the button, and it will stop. But really the goal of this is to look very intently at your image, making sure that it's not spreading posteriorly. So you see that filling there. So once it's in, then you remove the choke cars. He's looking at fluoroscopy. The reason why you're just not moving it, taking it out right away, is because he wants to make sure that there's no tail that follows it with cement. Because when I was a fellow, one of my co-fellows, he did not do that. He just pulled out, and there was a tail of cement coming out of the pedicle all the way towards the skin. So we had to dissect down and do foreign body removal of cement. So that's very important that you make sure that there's no tail sneaking back. So this can be done on multiple levels. This is my world that I live in because this is a person with multiple myeloma. You do 2, you do 3, and then some more fracture. And so you could potentially do it for many people. The recommendation, there was a question at one of my other lectures, how many of these can you do at one time safely? Again, very patient dependent, depending on the fragility of the patient, depending on the clinical scenario. But what's very important is that the companies that manufacture these devices are recommending no more than 3 levels at a time. But I've done up to 6 levels at a time, and even doing this for the sacral level. I've done it for femoral neck fracture in the palliative setting as well. So that's my lecture, if there's any questions. Before, what would happen is when you put the balloon in, before it would pop because of the heat. And so you get an eggshell, but you have a popped balloon. So what happens is that sometimes when the pop balloon happens, it deforms, and it might be a little bit difficult getting it out of the cannula again. So that can very much happen. Newer balloons that we have available in the States are more heat tolerant, not resistant, heat tolerant, and they can sustain a little bit more exothermic reaction before they deform. Yeah, so so that's very much off-label, not FDA approved, but I approach it as doing a surgical pin into the femoral neck. So you get your views. I go through the trochanter and go right in through the femoral neck.
By creating a space, you just inflate the balloon into the vertebra, is it?
That's correct.
Does it make like a lot of pressure in the vertebra itself?
Yeah, so the question was, if you're putting in the balloon and inflating it, does that make a lot of pressure in the vertebrae? Yes, it does. And you can gauge that based on the pressure readings on the balloon. So there's a manometer on the balloon looking at the PSI, and some of the balloons, their limit is 400 PSI. Newer balloons, limit is 700 PSI. So every time you inflate, you're creating pressure. You want that pressure if you want to lift back up the end plates. But you don't want so much pressure that it'll burst the balloon. So there's limits to your balloon. Right.
Actually, some studies says actually the model is more for kyphoplasty because of this embolism. So we can go for vertebroplasty. Why because the pain relief is not because of the increase in height.
That's a very good question. So I'm going to repeat his question. So some studies tell you that the embolisms could be because of the balloon inflation. And other studies, there's a big question of which one is better versus the other, vertebroplasty or cavity creation. It is very true that both will result in pain relief. There's one side of the fence that thinks that height restoration is very, very much needed because it restores the biomechanics of that spine as much as possible. However, that has never been proven to result in reduction in adjacent level fractures, and that has never been proven to be better with regards to pain reduction. What it has been proven to do is provide better height reduction. Remember, vertebroplasty without cavity formation still provides height reduction, but not as significant, not as great as a kyphoplasty with a balloon. So I use kyphoplasty a lot. I like cavities because of my patient population. I want control of my cement spread. I want it to stay in that cavity. But it's very reasonable just to do a vertebroplasty, especially if you don't need so much height restoration. You must do a vertebroplasty over a kyphoplasty for the older fractures that still hurt, because there's no point in using the balloon unless you're very scared of extravasation and you really, really want control of your cement spread. Other ways to control cement spread: viscosity of your cement. That's another way. If you are way in a hurry and your viscosity is still very, very thin and loose, you're going to get spread all over the place. You could also choose the different types of cements. There's so many different types of cements now. There is the regular polymethyl methacrylate. Companies have cements that have a 40-minute working time. Some cements are activated by radio frequency. Some cements are activated by heat. So some cements have silica in it. So it's ever changing. So that's a whole new lecture just talking about cement.
What's the experience of vessel plastic?
What?
Vessel plastic.
Vessel plastic?
Leaving balloon, the semen inside the balloon, and leaving the balloon inside.
Yeah, so I have not done that. We're starting to do the peak implant plasty. That is pretty brand new. The other implants in the past have not really caught on. There was an implant in the past where you used to stack things up. We've not done that. It's not done very routinely in the United States. There's another implant that we've trialed that we didn't really think it was any more beneficial, where it was a mesh, and the posterior side of the mesh, you the cement wouldn't go through, and the anterior part of the mesh, cement could go through. But as you're putting more and more cement, it goes around and goes to the other side. So we've trialed it. It never had any more benefit than the traditional approaches. So
So the vertebroplasty is you stay inside the balloon only, you leave the balloon
and then take it out.
Yeah.
So there's some contention with that whole concept. So a lot of the neurosurgeons have, especially in very, very weak bones, and I've seen this, it's awful, in kyphoplasties. If you put cement into that ball, and it's a very, very weak bone, and say that person falls, that ball in that very weak bone can pop right out. I've seen that. So what I've been doing for cementoplasty with a cavity, and I don't like that ball anymore. I continue to put more cement until the ball fills up, the cavity fills up, and then now we have a little bit of fingering, rough edges around that ball, so that it doesn't pop out. So a lot of neurosurgeons and interventional radiologists and pain physicians are starting to think that the ball is not a good idea. You need more.
How is the single balloon? How is the result? Single balloon kyphoplasty.
So that's single balloon kyphoplasty. So if you get that placed perfectly midline, you could do unipedicular kyphoplasty. Works very nicely. Goes spreading the cracks and crevices outside of the balloon. Sometimes you're in a hurry. Patient's not very fragile. You want to go fast. You want to do unipedicular, one side plasty. So if you put a balloon on one side, the goal is to get it midline as much as you can. If you don't get it midline as much as you can, and you still fill it, what happens is that they still get pain relief. They get wonderful pain relief. Your picture looks ugly because you're like, oh, what about the other side? Pain relief is still there. But anecdotally, there's no studies to show that there's more fractures afterwards if you did that. But anecdotally, I do see that maybe in the long term, that other side fractures, and the side that got the cement didn't fracture, didn't progress. I don't know if you guys that do it, if you've noticed that as well.
Can be done through oblique approach for pedicle?
That is absolutely, so her question was, can you do access to the vertebral body through the pedicle through a Scotty dog approach? And there's a name for that. It's called the en-face approach. E-N-face, F-A-C-E. And that's very, very nice for the lower lumbar, the lumbar levels, and even maybe the lower thoracic levels. If you try doing that at the higher thoracic levels, you remember what happens. You get more sagittal rather than oblique. And if you're more sagittal and you're going down a Scotty dog way, you're going to keep going, and you're going to keep going, and you're thinking you're going midline, but you were never oblique. You're going to end up going outside the anterolateral wall. You're going to break through that. So be very careful. En-face, very, very easy, very, very quick. And if you're a pain physician, you know the coaxial view. It's something very easy and in our nature to do that. So that I save that towards the end of the year for these fellows because I want them to know 3D first via traditional approaches. Any more questions?
Let's say it's a drug. It's a gas. It's a very good drug because you're using for the medical purposes. We call it as a drug. And a lot of controversies evolving because of the ozone. The main reason behind this is a lack of knowledge. Why we are using it? What is the pathophysiology behind this disease? In which cases we should do? In which cases we should not do? That is the main reason. People have started using any disc patient coming to the pain physician because they know how to enter into the disc. Now they have machines available, very cheap machines available nowadays in India. So just because they know how to enter into the disc, they have ozone available, they are putting that ozone inside the disc. And that is the major cause of failure. And that is why it is going into distribute. So that is why it is very, very important to understand before seeing the video. It is important to see in which cases we can do. which cases are selection. Selection is important for anything, for any procedure. Selection is important. So here also the selection of the cases is very, very important. So I'll just start with a very basic pathophysiology of the disc diseases. And in that we'll see in which cases we can use ozone. So we'll just select those cases, we'll just see those cases where we can use ozone. And I'll show you my recent case where I did ozone replaces. So we'll be covering this topic under disc pathologies, mechanism of action of ozone, and the ozone in disc pathologies where we can use. And finally we'll see the video demonstration. So now we know this disc is composed of three parts. One is nucleus pulposus, annulus fibrosus, and the end plates. So these are the three parts. Pointer is not there, no? You don't have pointer now. Okay. So I'll just show you here. So that's the nucleus pulposus here. These are the annulus fibrosus, and these are the end plates here. The nucleus pulposus is composed of basically composed of type 1 collagen fibers, and also it has some proteoglycans. You can see that's a proteoglycan. That's the structure of the proteoglycan. And this proteoglycan is basically responsible to hold the water inside the nucleus pulposus. So that is why you can see it's looking like jelly type material. So this jelliness is because of this viscosity, is because of these proteoglycans, because they are holding the water inside. Annulus fibrosus, you can see here, annulus fibrosus, it is like this. These consist of lamina of the annulus fibrosus. So this consists of basically a collagen fiber type 2, and it gives a good tensile strength to the disc. Now what is tensile strength? What does it mean by tensile strength? Tensile strength means whenever you put a pressure on anything, what will happen? If you put a pressure on anything, suppose the rubber is there. If you put a pressure on the rubber, what will happen? It will bulge out, it will thin out, and it will bulge out. This will happen. But in the disc, what will happen? Because of this lamina, because of interconnecting lamina, what will happen? The moment you start putting pressure, they start going inside each other. So there is a compression, there is increase in the pressure, but it will not bulge out. So that is why normally when the pressure, like if you jump from 10 feet height also, it will not bulge out. If you are sitting for a long time, it will not bulge out because of this structure. So this structure is very, very important to keep it inside the nucleus material inside the annulus fibrosus. And third is your end plates. So these are the end plates. So these are basically cartilaginous end plates. Earlier we used to consider it as a part of the vertebral body, but now it is very, very clear that it is a part of the disc. So these are the cartilaginous end plates. So like any other cartilaginous joints, this also undergo degeneration. Now what is the basic pathophysiology behind the disc degeneration? Normally, loss of proteoglycans and collagen, that is the main pathophysiology. Loss of collagen fibers. Now you can see this is the collagen fiber. So these are the proteoglycans. So whenever there is a degradation of the proteoglycans, because of decreased supply, accumulation of the waste products inside the nucleus material, that increases the pH, and that then pH goes down, it degrades the proteoglycans. Now you can see here. So this is normal proteoglycan, and this is degraded proteoglycans. So what will happen? It starts losing water, because this proteoglycan structure is responsible to hold the water. Now it will start losing water. It started losing water. So now you can see here, there is a healthy disc here, and you can see there is a dehydrated disc. So this dehydration is because of loss of water. It's a normal, it's a dehydration process. Now in a normal disc, as I was mentioning, that there is a pressure is evenly distributed around the end plates and the annulus fibrosus. That is because of this arrangement, lamellar type arrangement. But once the disc degenerates, what will happen? The moment you start putting a pressure, there is an uneven distribution of the pressure. At some point there will be high pressure, at some point there will be less pressure. So this uneven distribution will cause tearing in the disc. So just take an example of the rubber. Rubber, if you keep using rubber, it will remain soft. If you keep it for some time, when it hardens, the moment you start using it, it starts cracking. The disc is like the rubber only. So when it starts cracking, now you can see here. Such, this is a normal disc, healthy disc. That's a normal healthy disc. Oh, yeah. Yeah, perfect. Thanks. So that's the normal healthy disc here. You can see the very well hydrated disc, and this is a degenerated disc. And there is a tear here. That's a tear. You You can see here there is a tear here. So this tear is because of the degeneration of the disc. So initially there will be degeneration, then tear, and then herniation. So these are basically a sequence of the degeneration process. Now what happens with a tear? Whenever there is a tear, it is not a nucleus material, it is basically inflammation. This is all inflammation. So when there is a tear, it causes inflammation and it starts extruding the inflammatory products. And this inflammatory products get accumulated over here, exudate, and it will be seen as a high intensity zone there, HI side. So this is all basically what? This is all inflammation. This is important to understand. This is all inflammation. How to proceed?
No, it won't be changed by the
Acha, it will. So we'll have pictures like this. This degeneration with or without herniation. You can see there is a tear here. The prolapse. Now this portion is weak. It has started prolapsing. But this is a contained disc herniation. This is called contained disc. The outer annulus is intact. Now extrusion. Extrusion means the outer annulus there is a breach in the outer annulus and the nucleus material started coming out, but it is still in continuity with the mother nucleus pulposus. And sequestration means it is totally coming out. This is also important to understand. We'll come to know why it is important. Now these are the various pictures you can see. That is the contained disc herniation. You can see the outer edge is still intact here. That is the extruded disc, that is the sequestrated disc. You can see the sequestrated material here. So understanding the anatomy and understanding the MRI pictures, that is also important before we select our cases. Modic changes secondary to, as we already discussed about this thing, I think in the morning, yesterday I was having this lecture. So you can see here there is a modic changes. So what is modic changes? These are basically secondary to the disc deletion. So this happens at the vertebral end plates. Now you can see here. You can see blackness here, you can see whiteness here. So now we know that T1 images looking black, T1, T2 images looking white is basically because of the fluid. It is because of fluid. So why there is a fluid? This is because of the edema. So this is edema. Edema is because of the inflammation. So this is inflammatory edema. So type 1 body changes are basically inflammatory edema. Type 2 is fatty degeneration, fatty replacement. You can see white, and type C is basically sclerosis, sclerotic. So in the T1 and T2, both the we will see that's a black. So what is the mechanism of action of ozone? Now we understood the pathophysiology. So we'll correlate this pathophysiology with the mechanism of action of ozone. So we have understood one thing. Now we'll go to the second step. So what is the mechanism of action of ozone? One is by shrinking of the disc, shrinkage of the disc. So what it does, when it goes inside, the ozone causes degradation of the proteoglycans. So very important, I think the caution will definitely is going to come that in a normally degenerated disc, we are adding more degeneration to the disc because we are breaking the proteoglycans. So by breaking proteoglycans, again we are making it little dehydrated. So by breaking proteoglycans, it loses its capacity to hold water and it causes shrinkage of the disc. So that is the mechanism of action. So actually we are breaking the proteoglycans, which is normal degeneration process. We are making it more degeneration. But why we are doing it, we'll come to know that. Now, for these cases where we have contained disc herniation, suppose you have a picture like this. Suppose if you have a picture like this or like this, will it be effective? Even if you shrink the disc from here, it will not bring it this back. It will not bring this back. So in the sequestrated disc or the extruded disc, it is not indicated. Basically, we want a picture like this, a contained disc herniation, a contained disc herniation. And also, if you see the MRI picture, we need some hydration. If it is contained disc herniation and there is no hydration, if there is no hydration, how will it act? What we are doing, we are basically dehydrating it. By breaking the proteoglycans, we are dehydrating it. When we dehydrate it, it will shrink. If there is no hydration, suppose a person comes to you with a black MRI, totally black MRI, totally degenerated disc, contained disc, but I'll show you a picture like this. If you have a picture like this, it's a contained disc herniation, but totally black. It is already dehydrated. So will it work? It won't work. There is no scope. There is no scope of shrinkage because ozone is going to act only on the nucleus pulposus when it is hydrated. It only acts on the proteoglycans to dehydrate it further. So that is understood why it is important. So what we do is we go inside the nucleus pulposus. If it is hydrated, we will see first MRI pictures. We will see it is a contained herniation. We will see the hydration is there. We go inside and we inject ozone over here. When we inject ozone over here, it will break the proteoglycans, it will dehydrate, and over the time of 3 to 4 weeks, it will shrink the disc. And it will relieve the pressure of the nerves. That is the mechanism of action of decompressing the nerves. By inhibiting the inflammatory nociceptors. So ozone is again a very good anti-inflammatory action. But we must understand there is a concentration. We know about the concentration. So ozone is very good anti-inflammatory if you are using it below 35 mics per ml of oxygen. Above 50, it is a very, very highly inflammogenic. It causes inflammation. So this is also important to understand. So that is why you have to have a good machine, a calibrated machine. Don't use the machines which are coming with the knobs. We don't know what concentration they are giving. So this is important to understand. Above 45 or 50, it is highly inflammogenic. Below 35 only, it is anti-inflammatory action. Okay. So where is the role? Where we can use it? Now we know that we just understood the pathophysiology. So we have various structures where we have inflammation in the disc pathologies. Also we have, whenever there is a extrusion or the sequestration of the disc, there is some inflammation around the nerve roots. So that is why this is periradicular infiltration. So in fact, let me tell you, before intradiscal ozone, the first thing which was done was periradicular. It was injected periradicular to reduce the inflammation of the nerve root. And then this secondary role came, that intradiscal ozone. The first indication was periradicular, to reduce the inflammation around the nerve root. So this is all inflammation. It's just we cannot remove the extruded disc, sequestered disc. It is inflammation of the nerve root. We have to reduce the inflammation of the nerve root. Obviously, we cannot decompress the nerve root here. But over a period of time, we know after some time it usually degrades on its own, and there is a decompression, natural degradation of the disc material. Intradiscal ozone we'll use if you have a condition like this. Inflammation is there. Discal inflammation is there because on virtue of its anti-inflammatory property, and also if you have a picture like this. Now you know that this is type 1 body changes. So in these cases, intradiscal ozone has a very good role. Here our aim is not to decompress, our aim is to reduce inflammation. Some people are even using intradiscal steroids. But intradiscal steroid has a very, very major complication, that is chemical discitis, which is even more difficult to treat than an infected discitis. I don't know if you have seen any chemical discitis case or not. It usually heals by fusion only. Before that, patient did not get any relief. So it takes around 1 to 1.5 years. Anyway, so ozone has a very good anti-inflammatory action. It is as good as compared to any steroids, and also very safe. Infected discitis chances are almost negligible because it also has a very good antibacterial or anti-protozoal or antiviral actions. So these are the conditions where we can use ozone. If we have inflammation inside the disc, if we have inflammation in the nerve roots because of the extrusion or the sequestration, so we can give periradicular, or if you have a herniation which is contained disc herniation with a hydrated disc. There are other mechanisms of action of ozone. I will not go into details of this thing, by improving the microcirculation and oxygenation, by stimulating the fibroblasts and immunosuppressive cytokines. So these are not yet proved, but yes, definitely we have a good evidence for these things. So this is a video demonstration. These are the actual cases. So this patient came to me. There is no pause. So young female, 25 years female, sudden onset of low back pain, associated stiffness, radiation bilateral lower limbs. Now you can see the bilateral lower limbs 20 degree. So since it was just 20 degree and she had a very severe symptoms, young patient, so I have ordered MRI on the first visit only. So this was in I think May somewhere, and I prescribed some medications. So prescribed some medications and she improved after this. There was no sensory motor deficit. So she came with MRI, L5S1, PIVD with annular tear, mild relief in medications, more than 50% of relief in medications. With further this thing, I don't know what is this. Pain still persists, radiation is reduced. So after third visit, maybe after 2 months or 2.5 months, she kept visiting me. After third visit, when she improved, but it was around 50% of relief. So after that, we decided to go for the ozone nucleases. So that was the MRI picture you can see here. So that was a contained disc herniation with the hydration, very well hydrated disc, and contained disc herniation. So that is why we selected this patient for ozone nucleases. That was the L5S1, contained disc herniation. So these are the ideal patients. Young patients, contained disc herniation, ideal patient for ozone nucleases. And they respond very well also. There is a contained disc herniation. So just video demonstration how we do it. Okay. Okay. So the first step, as you know that for any intradiscal procedure, the sequence of steps are same. We have to reach our target area. First, identify the level, reach our target area. Once you reach the target area, you paralyze the end plates. Different from endoscopic discotomy where they don't paralyze the end plates. Here we always try to paralyze the end plates. So paralyze the end plates. So these are, you can see here. You can see here there are two end plates here, two end plates here. We are just trying to paralyze the end plates now. So once the end plates are paralyzed, we'll go oblique. So how much oblique? We'll try to reach to the center of the vertebral body. The superior arterial process should reach to the center of the vertebral body here. You can see here. That's the superior arterial process. It should reach here. We'll go more oblique. You can see here now. It is almost reached to the center of the vertebral body. And now you can see the intervertebral disc is over here. Okay. So that's intervertebral space, center of the vertebral body. Now we reach to our second step. Now that's the entry point here. That's the entry point, the center of the disc. Just later to the superior arterial process. So once we point out our entry point, we'll go end on view. moment we reach the disc, at times patient will complain of pain because of some peridiscal inflammation. Once you start touching the disc, once you enter into the disc, we'll go lateral to see that we are in the center of the disc and the depth of the disc. I can see here, now that's a lateral view. You can see we are in the center of the disc. We'll advance further to reach the center of the disc. Once we are confirmed, we inject contrast. Now contrast confirmation, we must go for the AP view. That is most important because in the lateral view we will not come to know whether we are in the annulus or we are in the nucleus pulposus. Our target is always it is a nucleus pulposus. It is never annulus. So we have to confirm. So how will you confirm? If it is in the annulus fibrosus, it will get accumulated on one side only, around the tip. But if it is in nucleus pulposus, it will spread to both the sides. I can see it spreading beautifully, but still we cannot say that we are in the annulus. So for that we have to have a AP view. I can see here AP view. It is spreading to both the sides. We are in the nucleus pulposus. Once we reach, when we are confirmed that we are in the nucleus pulposus, we will take around 6 to 8 ml of, normally what we do is we take around 10 ml of ozone. I usually take 29 micrograms, 29 or 30 micrograms of the ozone, 10 ml freshly prepared. Then put it over the needle and start injecting. It's not possible to inject ozone inside the disc. You have to put a pressure. You have to put a pressure for at least 3 minutes. Put a pressure, initial 2-3 ml it will take easily. And after that you have to keep a pressure on the disc. Keep a pressure for 3 minutes to get it distributed inside the nucleus pulposus. After 3 minutes, what you can do is, without removing the syringe, because if you remove the syringe, everything will come out. Don't remove your syringe. Come up to the annulus. Come up to the annulus and then detach your syringe.